how should I treat lupus? Where should I start when I see a patient with lupus? Because as you know, it can be complex and even often overwhelming for the medical team. So the question always, am I seeing a patient with a single organ or multiple organ? Is it only the skin, or there is a skin and kidney and brain? And definitely you need to tailor and change your treatment according to this. And that's something you can see on the exam, but you have to be careful. When you examine lupus, there are a lot of things that you can't see it on the exam. This is why it's very important always to do a blood test, urine test, and imaging if needed. So for instance, when you look at the blood test, something we see it in patient with lupus is hemolysis, when you have destruction of the red blood cells, low platelet, or when the kidneys are inflamed. And this can occur up to 60% of patients with lupus during their life. We call it proteinuria. Often proteinuria doesn't hurt and the patient don't feel it. This is why you need to do a urine analysis, because if you don't stop proteinuria, the patient will end up on dialysis and kidney failure. You need to set goals for yourself and for the patient, and this will improve the collaboration and patient adherence to medication. So I always spend time talking about what's currently involved when we see the patient, because as you know, lupus, we define it as well, the disease of 1,000 faces, and not all patients are similar. One patient can have skin problem, other patient can have damage in the arthritis in the joints or inflammation in the brain. So you need to decide which organ is now inflamed and which medication you're going to use, and set a goal for yourself. Because we know, for instance, if you have kidney inflammation and proteinuria, it takes sometimes a year or even more to improve or to start to get some recovery. But if you have probably arthritis, you might get some improvement after 4 weeks or 2 months. This is why this is very important. This is just an example here on target goals. When you have kidney inflammation, proteinuria, you need to set some goals. And one of the goals always, we need to maintain the kidney function. We don't want the patient to be on dialysis or have end-stage kidney disease. Okay, but at the same time, we need to be careful with a lot of comorbidities. And I will explain what's this. When you have lupus and chronic kidney disease, the patient is at a risk for having stiffness in their vessels, which we call it atherosclerosis. And that puts the patient at a risk for myocardial infarction, heart attack, and stroke. You need to manage the cholesterol. You need to manage the bone health, which is osteopenia and low bone density and osteoporosis. So you can see a lot of things can happen at the same time here. Now let's start moving on. How do we treat things? This is a complex slide, but I need you to focus here on the colors a little bit. And this reflects what happened over years, okay, since 1950 to nowadays. And I wish we had more red colors, because the red colors mean the drugs that are approved for lupus. The blue colors are the medication that we use, but they're not approved for lupus, okay? So you can see back in the 1950s, we got initially aspirin, hydroxychloroquine or Plaquenil, and the steroid, which means prednisone. And in 1970, we start using different immunosuppressants. And I know you're all familiar with this: methotrexate, azathioprine or Imuran, mycophenolate or simply Cellcept, and Myfortic. But you can see this is all blue. Not only this, look at this. From 1960 to 2010, we've had more than 20 trials and all were negative. And finally, in 2010, we got a medication biologic, I will talk about later on, called belimumab or Benlysta, approved finally for lupus. It took us another 10 years to get more medication. It's again, this time for kidney, lupus nephritis, belimumab. But look what's happening lately. I think we learned how better to do trial for patients with lupus. And we're getting now more positive trial. Voclosporin, again for kidney, anifrolumab for lupus in general. And there is an extensive list. And I'm so happy to see this. Look at the list here. And what I'm showing here really are trials that are in phase 2 and 3. So for a medication to get approved for lupus and show efficacy, mean it makes a difference in the disease activity, it needs to be positive in what we call drug trial phase 3 or P3. Phase 2, it's also an important step. And if a drug, particular drug passes phase 2, it moves to phase 3. But look at this. We've got now a new molecule, very promising, iberdomide, anti-BDCA2, very difficult names to pronounce, litifilimab. You've heard about CART analysis. And look what's happening with the kidney. So many trials are already in phase 3, and hopefully very soon we'll hear about it. Obinutuzumab, secukinumab, anifrolumab. And you can see how many trials are actually in phase 2. And a lot of these trials are actually promising. So hopefully we're going to see more red color and change things around. Not only there is a lot of drugs, look what's happening here. And I have to involve you in this because we need all to understand why we have been struggling to get new drugs for lupus. Those are the tools that the doctors use in clinic, but mainly in clinical trials. And you can see in the 1990, we introduced something called SLEDA, and this was developed here in Toronto with many scientists from all around the world. And the SLEDA stands for Systemic Lupus Disease Activity Index. And there is another tool, the BILAG, or the British Eye Lupus Assessment Group. Not only this, more recently, we start developing instruments that focus on a specific organ, like skins, classy, and lately they developed these complex tools that mix different tools together. You're wondering why we're doing this, because you've seen here that there was a gap on getting new trials, new medication for lupus. And we think part of it is related on how we've been assessing the drug in clinical trials. Maybe we don't have the best tool. So many factors could be related to the failure of the trials that we have in the past. So that brings me here to the question, which tool should I use? How should I assess lupus? And really here we always say, choose whatever you're familiar with, as long as it's valid and measure what it's supposed to measure. So if you have kidney inflammation, you need to measure the proteinuria. If you have arthritis, you see always the doctor trying to put some pressure on the joint and see if it's swollen, if the patient is in pain. So, and counting the number of the joint, but we also do often ultrasound and so on. So all these important tools to help you in the assessment of lupus. And this is the SLEDA that I reported earlier. And you can see it includes different things that the patient can have: seizures, psychosis, headaches, inflammation in the joints, in the muscle, and so on. And at the end, you get a total score. And when you are in a clinical trial, you want the score to drop to say that the medication is making difference. Not only this, you've seen recently, probably you've heard about it, in 2019, the American College of Rheumatology and the European EULAR developed together a new classification criteria for lupus. And as an entry criterion here, as you can see on the top, you need a positive ANA test, but that's not the final thing. You need clinical things, which means skin rash, arthritis, and you need blood tests. And when you have these two together, you can say that the patient met the classification criteria, but we have to be careful not to mix between this classification criteria and a diagnosis that continues to rely on the expertise of the rheumatologist that you're seeing. This is why it's very important to be seen by an expert, first of all, rheumatologist, and someone expert with lupus. Let's shift gear now and start getting closer to the treatment, how we treat lupus. So we talked about the traditional treatment, right? Antimalarial, they're very important, Plaquenil or hydroxychloroquine. But we have as well immunosuppressant and prednisone. Prednisone is very important. I mean, it's a very efficacious molecule, but at the same time, we don't like prednisone because it has a lot of adverse events. And hopefully one day we don't need to use it. But until now, we have to use it. Why? Because prednisone stopped the storm right away or shut the fire quickly. And in some manifestation, like when you have lupus inflammation in the kidney, you need something to work quickly, otherwise you lose the kidneys. And same with other manifestations such as brain or when you have a lot of skin involvement. So this is why prednisone continues to be an important part in the treatment of lupus. And the question is, how much prednisone should you give? And this is actually the scheme that the doctors follow. You see low dose, anything between 10 to 20, moderate 20 to 40, and large dose up to 60. And really, it depends on what the patient has. If you've got some skin or arthritis, we often go to low. But if you have heart inflammation or brain inflammation, we go to the maximum, which is 60 milligrams. And the second question is it the time to start using immunosuppressant? Should I use Plaquenil? I mean, all these things are very important when you come to the clinic and should be determined with your physician. So that kind of a general overview on how we assess the patient in the clinic. We're using different tools, talking about the goals, sharing with the patient the adverse event of the medication. All this is important because it should be a teamwork together. If you don't work with the patient, you will never achieve good goals. Let's shift gear here and try to cover, because I want to show you how much is happening in the world of treatment of lupus. And we're going to target today different pathways. So some of the terminology are complex, but I want to introduce you to this. So the pathogenesis of lupus, which means what's happening in our immune system that we're getting lupus, is different from patient to patient. So the major key player in our immune system, and our immune system is there to protect us against infection. So the main two players are something called B lymphocytes, and there is T, as in Tom, T lymphocytes. But in lupus, particularly what's happening, the immune system is not functioning well, and it's attacking the internal organ of the lupus patient and other organs. So this is why we get different manifestation of lupus. So some of the pathway that we like to target, it's B, but there is also interferon. We've learned about it recently in clinical trials. And there is multi-target when you do too many things at the same time, targeting different approaches. Let's start with the first one. But first, I'm gonna share with you some of the situation that we see in the clinic. So this is a patient that you're seeing. She's 24-year-old, very young patient. She's had 5 years history of lupus. She did have skin rash in the past, joint pain, and something we call pericarditis, or difficulty when you're breathing. It hurts over the chest. And positive serology, which you hear the doctor always saying, dsDNA antibodies and the complement C3 and C4, which are low. So tell you the story here. This patient tried methotrexate, and she's on Plaquenil and prednisone 15 milligrams. And what's happening here, because we don't like prednisone, we want to lower always and stop prednisone. And every time we try to do this, the patient gets another flare. And then we say, you know what, methotrexate doesn't work. Let's try the different medication, Imuran or azathioprine. We tried it for 12 months. The patient's still not doing okay. Then what's the third medication that we have is Celsep. And as you know, there are 3, methotrexate, Imuran, and Celsep. Those are the main 3 immunosuppressants for lupus before the biologic. And we did here try Celsep. She did have 50% improvement, but not completely. And still, you can't lower prednisone below 10. So what do you do in this case? I don't expect you to answer the question here, but I want to show you what's happening in the world of biological treatment. And we're happy now that we have on the market anifrolumab, which I will talk about later on, belimumab or Benlysta, voclosporin, I will talk about it, and other medication. The option F here, it says continue prednisone. Okay, great, we can continue prednisone, but we need something to help me stop and lower the dose of prednisone. So what we can do here, we use the B lymphocytes approach. And let me tell you about it. So this is the B, and there are different receptors. And we've been trying over the last 20 years with different molecules here. I'm not gonna list all of them. And majority of our trials were negative until 2010, where we got the first molecule, which belimumab, and I'm gonna bring you to this. So there was 2 major trial phase 3. Remember, you need phase 3 to get on the market. We call them Bliss 52 and 76, and that was great. But what I want to show you today is when you have a medication that passes the phase 3, it gets on the market, and then we need to learn how to use this medication in the market, which means which are the best medication, the best patient that could benefit from this. And I'm going to show you some data. Another molecule called rituximab, and here the story wasn't so positive because 2 major trials for the kidney and everything outside the kidney, which means skin and joints, unfortunately, they were negative phase 3 trial. But despite this, the American College and the European College of Rheumatology, they continue to recommend these medications for difficult cases in lupus. So this tells you that this medication still works in lupus, but we were not able to show this in a clinical trial for different reasons. And I showed you earlier some of the tool, probably it could have related to this, or maybe the way we designed the trial. So this is how Benlysta works, or belimumab. What it does actually, it targets certain receptors to stop the function of the B lymphocytes. And earlier I showed you that B and T are very important in the underlying pathogenesis of lupus manifestation, sorry. And there was also a follow-up trial on belimumab, which was subcutaneous injection. And also the results here were positive. So in this trial, they measured improvement using something called SRI, SLE Responder Index. I don't want to give you a lot of complexity here, but we can see here, which is the solid line, an early differentiation around week 16. Look at this, an improvement for patient who did receive this molecule, belimumab. It's superior compared to patient who did receive standard of care. So 61% at the end of the year end up being responder, which means showed efficacy, improvement on this medication, while only 48% of the patient who receive standard of care. And standard of care is usually Plaquenil, prednisone, and other immunosuppressant. While in the other arm, you just added Benlysta on top of all other medication. And I often get this question in the clinic, are we gonna stop other medication? The answer is no. We add to existing medication, then we start stopping the most toxic medication, which is always prednisone, then hopefully followed by the immunosuppressant, and we'll keep the biologic and Plaquenil if possible. So this was data from clinical trials. And over the last few years, because we had this molecule on the market, we've been doing some study in regular clinical practice, not drug trials. There was a number of studies, we call them Observe. And we've had even our Canadian study here, but there was also from Germany, Spain, and different parts of the world. And this is the study that we done here in Canada. And what we showed actually at 6 months, that there is improvement similar to what we seen in drug trial. And more importantly, patients were able to lower the dose of prednisone, okay? So this was a study as well from the state, and larger sample size, as you can see here, more patient involved, 500. And the message is similar. At 6 months, there was improvement in at least 50% of the patient. Not only this, so this graphic showed here the C-Day, the tool that I showed you earlier, and you can see the score was high, it dropped over time. But really, which is more important here, that we see a drop in the dose of prednisone over time, and that's very important. Now, if you're wondering what happened in real practice here, and we analyzed the data, we looked at it, and which patient, and this is actually the slide here that combined all the observed data from all around the world. And the sample size is 830 participants here. And you can see, when did they use this medication? They've used it in 75% of the situation where previous treatment just didn't work, or they used it to be able to lower prednisone, or the patient condition were not getting better, or it could have been a decision between the patient and the physician, or previous regimens simply causing side effects. So again, this is what's happening in real practice. And if you're wondering, okay, now, which patient did receive this? What kind of lupus manifestation they've had? It's not a surprise to see 72% have arthritis, because this is very common in lupus patients, as well as skin manifestation. But other issues, we call it constitutional, when we have a lot of fever, and hematological manifestation, kidney, and so on. But if you combine together skin and arthritis, it constitutes 87% of the manifestation that we seen in this data. And if you're wondering what other medication these patients were receiving when they started belimumab, they were majority are on prednisone, which is not a surprise here because they're active. They are taking antimalarial, which is hydroxychloroquine or Plaquenil. 60% were on different immunosuppressant, which mean methotrexate or Imuran or Salcept, Myfortic. But also here you see the breakdown between AZA, methotrexate, and Salcept. And there is something called cyclosporin, but I'm not going to talk about it a lot. We don't use it often in lupus patients. So this is again just to show us what's happening in real life, in the real world, when a medication gets to the market. Now we talked about biologic and immunosuppressant, and this is a data analysis from our clinic here. And what it shows you is we compared the data from our clinic where we don't have access, unfortunately, to belimumab. Because as you know, although it's approved here in Canada, it's not we don't get, it's not covered, which means the patient has to pay for it, which is impossible because it's very expensive. Only patient with good drug plan insurance can have access to this medication. And this is a major problem because it's creating a problem in the management of lupus. And talking about accessibility for the patient for this medication, it puts a lot of challenge. So hopefully this will change with time. But when we compare how patients in our clinic are treated compared to the data from clinical trial, you can see here, those in orange color, the patient who did receive the biologic, and this is in our clinic, the blue color. And what we analyze here is the damage. And the curve here is lower, which means the patient are getting more damage to compare to patient who did receive the biological treatment. So there is no doubt when you add more treatments such as biologic, you will improve things and you will prevent damage, which we were not able to do it in our clinic, again, because of the limited access to biologic in Ontario. And now the question is prednisone. And what I want to show you here, the damage that you saw on the previous slide, majority of it is related to prednisone. As I said earlier, prednisone is a good medication, but a bad medication at the same time. We like to stop it as soon as possible, but we can't because we don't have good medication for all manifestation yet. And you can see here, and the patient always asks me in the clinic, which dose is bad? I can tell you any dose of prednisone, if you take for a long period, it's not good. And you can see here, if you take 18 or more, or 12, or even anything between 0 or 6 milligrams, greater than 0, which means 1 and 6, there is a risk of adverse event, of damage. And what kind of damage that we see often related to prednisone? Cataract, avascular necrosis, which is destruction in the hips and knees, often unfortunately lead to hip replacement or knee replacement at a young age, osteoporosis and stiffness in the vessels, infarct and stroke. And we know other studies have showed clear relation between prednisone dose and atherosclerosis. The higher the dose, the higher the cumulative dose which you take over years, the higher chances of you running into trouble. And this is actually what we're trying to explain to the people who review the application for the biological treatment, not just only belimumab, but you've heard as well with anifrolumab that the story wasn't very successful. Now there is a reappeal, and we hope that this will pass what we call the carrot, which I'm going to show you later on. But I want to stress on this because they need to realize that prednisone is not the solution, and we need to change the way we treat our patient. And I ask you here that the patient needs to team together, and your voice should be heard by the people who approve this medication. So there is a lot of effort that being done by physician and the healthcare team and by you as the patient, but I think we should do more because they're gonna only listen to you. So the second pathway that I want to talk about is interferon pathway, which is anifrolumab. And again, this is a very positive data here, which is so nice to see finally in drug trials. So anifrolumab, what it does, it targets a different pathway called interferon. And we know already that interferon is very involved in the disease and the manifestation of lupus. And there has been first a phase 2 trial. Remember, always we have phase 2, then phase 3. And that's a trial we call MUSE trial. But what we need to just the conclusion here, that was a very positive trial and led to development of the phase 3 anifrolumab that I'm going to show you here. But this is something from this trial, the phase 2, where you can see improvement in the skin. And again here, this is the arm that the patient who did receive anifrolumab, and it's superior to what we call placebo. Placebo means when the patient just receives standard of care as opposed to standard of care plus the new medication. So when you add anifrolumab, you get better response. And this here, you can see the resolution of the skin rash in this patient. Not only this, they analyze also the arthritis, which is very common in lupus patient. And we can see a nice separation between this arm. The gray is the placebo, and the upper part is the patient who received the anifrolumab. So starting from week 12, 16, we did see the separation, and it was maintained up to 1 year. Now, that was phase 2. And we moved to phase 3, and we called it TULIP 1 and TULIP 2. Here, the story was successful, but there was some bumps down the road. As you can see here, the first trial showed no difference between the placebo and anifrolumab arm. Anifrolumab is again the red color. And often in drug trial, you need to see a good separation and what we call statistical significance to get the medication on the market. But really, when they look carefully at the data, just to show you how these trials can be, how the results can be changed, and many things affect the results of the trial. It doesn't mean always that the drug is not efficacious for lupus. So in this trial design, some patient did have to take anti-inflammatory medication NSAID for some reason. And by the study design, if the patient took any of these medication, even if they had an improvement, they were defined at the end as non-responders. And there were 8% of the patient who received these medication, and that tipped the equation. So if you exclude this, this item here where you make the people who received NSAID non-responder, if you make them responder, you can find a statistically significant result. So that was TULIP-1. And unfortunately, at the end, this trial was defined as negative. But the story here was better with the TULIP-2, which is a very similar trial to TULIP-1. And the outcome is a little bit different here. But the story here is important to say that at the end, patient who received this medication had more improvement, 48% compared to those who received 32% compared to those who received only placebo. It has adverse event, and I have to talk here about something important, that 7% of the patient did receive what we call herpes zoster or shingles. That's why we think that patients with anifrolumab who are going to get this medication now in the future should get a vaccine for shingles prior to starting this medication. But let's bring it back to here to the story, successful story, that this medication showed positive results in phase 3. And this is again using here a different tool called SRI. What I want to show you here again, that there is a good statistically significant difference between anifrolumab and placebo. So at the end, TULIP-1, it did not show a statistically significant because the results are very similar between placebo and anifrolumab. But if you go to TULIP-2, they changed the outcome here, and this was statistically significant. And you can see the difference here between patient who received placebo 32 as opposed to anifrolumab on top of the standard of care. So there is a difference at least here of 16%. So additional 16% of the patient will show improvement if you add biological treatment. So this table here, just to summarize things around, and I know it can be a complex table, but I want to involve you in what's happening now in the lupus trial. So remember, the first trial was positive, TULIP-1 was negative, and TULIP-2 was positive. But if you flip the outcome, for TULIP-1, which was negative, you change this trial in positive. And here it shows you how vulnerable are these trials and how things can change based on the measures and the outcomes and the definition of what's responder and not responder, as I showed you with the use of anti-inflammatory medication. But all trials showed the same signal. We've been able to show that the patient are able to drop the dose of prednisone if they took anifrolumab, which is very important. They did have less chance of having active disease down the road, which we defined as a flare, which means when you go into remission and you have activity again. And when they measured the skin, in those who did have skin, there was an improvement with a tool called CLASI. So overall, this led to move the portfolio of this medication to CARED, which stands for Canadian Agency for Drugs and Technology in Health. But probably you've heard that the application was rejected, and now there was a resubmission to look one more time at this application. And really, we hope that this medication get approval by CARED, because you know that belimumab did not get approval despite multiple applications. And if the story happens again, this means only patient with good drug plan will be able to have this access to this medication. And this is not fair. And you should advocate and talk to the people who approve this medication, because I repeat again, your voice will be heard by them better than us. So I want to move here to the very important aspect of the presentation today, which is multi-target. What does it mean? I showed you earlier B pathway, interferon, but in some trial, they're combining too many things at the same time. And probably this is the future. The more we learn about the pathogenesis of lupus, We think that this could be the future for treating lupus. So let me share with you one of the situation that the doctor can see in the clinic. So you're seeing here a patient, she's 33-year-old, who did have lupus for 2 years. Skin rash, hair loss, joint problem, positive serology, as we said earlier. Not only this patient had problem with the kidney when there is proteinuria, inflammation of the kidney. So what they did in the past, they used prednisone and something called cyclophosphamide. Maybe you've heard about it. It's a medication that we give in the IV, but we tend not to use this medication if possible a lot because it has a lot of adverse event in terms of hair loss. It can affect the fertility because it can induce sometimes early menopause. So this is why we don't like to use it as a first line. We don't like to use it many times because the more you use it, the more you're in trouble with the patient in trouble in terms of adverse event. So this patient is on Plaquenil, Interferon, and prednisone. And she developed down the road chest pain, which we found that the heart is inflamed on an MRI. We call it myocarditis. So what we did in this case, we increased prednisone and we said, okay, we're using Interferon here, and the patient developed this complication while on good medication. Then this doesn't work, and we stop and start something else. And what is something else here? When you have such a major organ involved, you can use Salsapt, you can use cyclophosphamide, but we don't want to use cyclophosphamide. So we tried Salsapt, and unfortunately, the patient developed allergy. We discussed the option of cyclophosphamide because we don't have a lot of option here. And the patient said, I don't want to use this medication because I've used it in the past. And I agree with the patient. If we use it again, there is a high risk of toxicity, particularly ovarian failure. So let's think together. What can we do here? So can we use some of the new medication? I showed you earlier rituximab and belimumab. But there is something called tacrolimus and voclosporin that I'm going to show later on, and these are more for the kidney. But in this particular situation, what we did, it's multi-target therapy when you combine different medication together. And particularly what we did in this case, we use rituximab that suppress the B lymphocytes, and then we added belimumab that maintained the improvement that we have in this particular patient. So that's an example that I'm showing you. And probably this is the way to go with the treatment of lupus. Now, if you're wondering, how did we get to this concept of multi-target therapy? This is something that was introduced initially in 2015 when they were treating lupus nephritis. And what they've done there, in addition to the standard of care for lupus nephritis, which remember, it's Salsapt or Myfortic, prednisone, and Plaquenil, they added a molecule called tacrolimus. And they treated the other group of patients with cyclophosphamide and glucocorticoids. And you can see here that the results were superior with this molecule called tacrolimus. But again, the message here that was very important from this trial is combining different medication together. Now, I showed you earlier the data on belimumab in what we call extra-renal, mean anything apart from the kidney. But more recently, there was a drug trial for the kidney. And not only with belimumab, again, it's the busy slide. Remember how many drugs we have now in phase 2 and phase 3. But today I'm going to focus on those that are very close or almost phase 3 particularly. So again, B and T lymphocyte. So tacrolimus, which I showed you on the previous slide. And you've heard about voclosporin also, which was a phase 3 approved drug trial now for lupus nephritis. We'll talk as well about the drug under the B, which are for lupus nephritis, particularly belimumab and interferon. So this was the first trial here, which used belimumab in lupus nephritis. And let me explain this difficult slide. So in summary, what they've done here, they always add the biologic to the standard of care, which means patients are receiving Plaquenil, steroid, and Salsapt in one arm, standard of care. And the second arm, they said, okay, I'm going to add now belimumab to the standard of care. And what they found here in the results, which I will show you on the second slide. But first, if you're wondering which patient goes in this trial, it's important to learn about these things because we translate this to our clinic, and always we have this stable in our mind, because I want to think the patient that were in the trial, is that similar to the patient that I'm seeing in the clinic? And the results are yes, because you see here, the majority are female, which we see in lupus trial, but they did have as well male lupus patient. Mean age is 33. And when you have kidney inflammation, you hear the doctor always talking class 3, 4, 5. So you can see here in summary that they have distribution of different classes. Okay, so very similar again to what we see in our clinics. And the result here are showing that if you add belimumab to the standard of care, it's more, you will get more response compared to patient who did receive only placebo. So 32% responder as opposed to 43 when you add the biologic, okay? Not only this, look at this. This is the proteinuria. Remember, when we have lupus nephritis, inflammation in the kidney will leak protein. So to measure improvement, we always measure protein in the urine. And we ask you often to collect urine over 24 hours. And in this trial, at week 24, they start to see that patients who are receiving belimumab in the blue color are superior. They're achieving better improvement compared to only standard of care. And that was maintained throughout the trial to the end. Okay. Not only this, now they looked at the damage, which development of worsening in the kidney and death and dialysis even. And what we see here are doubling of the serum creatinine, which means increase in the serum creatinine that reflect the kidney function. Bottom line, what we see here, that the patient in placebo, they have more problem, which means more patients are having increase in the serum creatinine or death, unfortunately, if you don't add the biologic belimumab. So in conclusion, these new molecules help us to control the lupus. So the second molecule on the market that was also positive trial, it's voclosporin. And this was approved in Canada, but unfortunately, it's not yet on the market. And the other challenge that we're gonna have with this medication, that it's so expensive. So we don't know yet if how it's gonna get when we have it here and who's gonna pay for this medication. So this is the positive trial that they had. And again, let me explain it. Similar to other trial, you receive standard of care plus voclosporin, or the other arm in the trial will receive only the standard of care. And if you look at the color here, the blue are the patient who did receive the voclo in addition to standard of care, and it's superior at week 24 and at 1 year, 6 months and 12 months. So always, if you add the voclosporin to standard of care, it's superior to the patient who did receive only placebo, 52% here and 50 as opposed to 70. But something very important, I want to bring your attention to it here. Look what's happening here. The way we treat traditionally lupus nephritis is we give 40 to 50 milligrams at the start, but we've learned lately that we can use less prednisone. We're starting nowadays 20 or 30, depends on how active is the lupus nephritis. Not only this, in this trial, they brought the dose of prednisone to below or close to 5 milligrams at week 16. This is very innovative, and I think they were able to do this because of this molecule, voclosporin. Because what it does, it stabilizes the cells in the kidney, and the kidney stops losing protein, and that allows them to drop the dose dramatically. This is very important because we know the adverse event of prednisone. And now they published something called Aurora 2, which is an extension up to 2 years, and the message still holds that patients who receive voclo are showing more improvement and sustained improvement up to 2 years compared to those who did receive only standard of care. Not only this, you can see early differentiation, which means people who are receiving the voclosporin, they start to improve fast in the trial by week 25, and this is sustained and well separated from those who did receive only standard of care. So there is no doubt it's a very good molecule, and hopefully we'll see it on the market here in Canada. The second molecule, and the last that I'm going to talk about today, it's a new biologic as well, obinutuzumab. It is like rituximab, which target the B lymphocytes. It's a very promising drug because you can see here also it's showing good response. Again, patient receiving this molecule compared to the receive only standard of care, and we see good separation and superiority. So there is no doubt that this is a very promising result, and we're waiting now for the final phase, which is always, remember, to get the drug on the market, you need phase 3. So to summarize, look what's happening here. If we talk about the kidney, I showed you data on voclosporin, tacrolimus, that's the T lymphocyte. If you want to bring it to the B, we talked about belimumab obinutuzumab, and also anifrolumab. There is ongoing trial. We don't have the data yet for lupus nephritis. Hopefully soon, and hopefully positive. We'll see. But for what we call extrarenal, which skin, joints, and other manifestation, we have a lot of things happening here. So I showed you data on targeting B lymphocytes, which with rituximab and belimumab. Showed you data on anifrolumab, which is now on the market available. But there is very promising molecule as well going, maybe you've heard about iberdomide and other molecules as well that are moving to phase 3 and hopefully will be positive. And probably you've heard about the new emerging data from something called CART analysis, CART data, CART treatment. And again, if you have a question on it, I'm happy to answer later on. So there is no doubt that there is a shift in the way we're treating lupus. And this is the new paradigm that we talk about in lupus nephritis management. So in the past, we used to treat patients and wait until they get improvement and reassess this after a year or 18 months. I can tell you that things are shifting, are changing around because of the new molecule that we have, the voclosporin, the tacrolimus, and the biological like belimumab. So now the recommendation is to assess at 3 months for kidney inflammation. And you want to achieve a 25% decrease in proteinuria. If it's not happening, we shouldn't drag on forever. We should be innovative and start adding some of these new molecules, such as belimumab, or even voclosporin or tacrolimus. And at 6 months, we want to see 50% decrease in proteinuria. And if we don't, we need to add medication. Not only this, I can tell you that things are going to change around, and it is already. Because at the beginning, if you look at the biopsy and you see that the patient has a lot of factors or markers that can tell us this patient has a very severe kidney inflammation, we think that we should add from the beginning multi-target therapy, different molecule together to induce, to get a quick improvement and avoid kidney failure. Last thing I want to say here, that it's very important to avoid kidney flare down the road, because remember, we have certain number of the cells that function in the kidney. And that's what I explained to the patient. This is why it's important to adhere to the treatment, because every time you stop the immunosuppressant or we don't take the pills, the kidney will get inflamed. And every time the kidney get inflamed, you will lose some of these cells. And with time, you move slowly to kidney failure. There is no way to go backwards. So this is why we need to take these pills and make sure we get improvement. And based on the last slide that I showed you, there is no doubt that the way we treat lupus is changing. And hopefully we're going to move to what we call personalized therapy. Every patient has different receptors or different pathways. And again, it brings us to the idea that lupus, 1,000 faces, differently manifesting and different pathogenesis. And we should treat patient probably differently down the road. And hopefully, again, as I said earlier, we need your voice to get more medication approved, paid for the management of lupus in Ontario. I would like to acknowledge everyone who's been involved in a lot of these research, patient families, the Toronto Lupus Clinic, and you can see here different donors, the Lupus Ontario Arthritis Society. I don't want to forget anyone, and other supporters of our Toronto Lupus Clinic. I want to acknowledge the team, and unfortunately here I don't have everybody in this picture, but you can see a lot of faces that you recognize. And here again, some of the team, we didn't have everyone in the picture, but this was during COVID. That was very recently, so we're allowed to remove the mask, but as you can see, we're very far from each other, and this was outside. Probably everyone is freezing here in the cold. So I will stop sharing here, and I'm happy to answer all your questions. Let me just figure out how to stop sharing. Here you go. Okay.
Wonderful. Thank you very much for that presentation. We have a number of questions, so we will try to get through them all. And just before I start going through them, I'll also mention again to everybody that if you do have a question, feel free to type it in the chat. You can do so either in that Q&A banner of the portal through which you're viewing this, or on that right-hand side chat bar. You can list your question too. So it's quite the spectrum of questions. And so I'll just kind of go from the top and work our way down to as many as we can. So could you comment on the value of, or is there value in, repeating the anti-dsDNA and C3, C4 in patients who are already on treatment? And is there also an effect in C3, C4 if someone happens to be pregnant?
It's very important to measure what you have mentioned here every time, at least every 3 to 4 months, you see the patient in the clinic. Not only this, also the urine analysis and many other aspects, because this can tell us how is the immunology or the serology of the lupus, okay? As we know, probably 50 to 60% of the patient, they have what we call clinically and serologically concordant, which means when the serology, the DNA is high, the lupus will be active. But when the DNA drops with treatment, the clinic will get better. So the doctor often look at these markers to decide on how's the trajectory of the disease and sometimes anchor the treatment. So the answer is yes. Regarding pregnancy, not only the complement, even DNA, dsDNA are important, all these markers, but really for the pregnancy, what matters more is we never recommend the pregnancy if the patient is not in remission. And not only this, they have to be in remission for at least 12 months, particularly when we have major organ like the kidney or the brain. It could be less if something less major, such as skin or other organ, but always you gotta be in remission, not on toxic medication, and you have to work with the team very closely, because the last thing is you wanna start with the pregnancy not in remission. The outcome will be bad for both the mother and the fetus.
We have a few questions related a little bit to clinical trials. One question is, would you be able to explain a bit what it means to be in a clinical trial to help people better understand that?
Exactly.
And then is there a way that people can kind of keep up to date on clinical trials and potentially get involved if they'd like to?
Absolutely. So to be in a clinical trial, you have to have a center that they have a trial center. So for instance, I can give you an example at the Toronto Lupus Clinic. We have a trial center where we get approached by different trial phase 2 and phase 3 to be in our unit. And once we have a trial, we talk to the patient and see if they are eligible. So first of all, majority of the trial, you have to have activity, which means skin inflammation, skin rash, arthritis, or proteinuria. And then we determine the eligibility in terms of how much activity, safety for the patient. All these conditions needs to be taken into consideration, because there are situations where the patient are very active. We can't do this. If you have brain inflammation, for instance, up until today's, we have no trials for this, and they don't allow patients with a lot of inflammation in the brain to go into drug trials. So really you have to work with your rheumatologist, lupologist on this and decide if this is a good choice for you. And if it happens that at your center, or if you are seeing your rheumatologist in the community and they don't have access to trial, you can discuss this with them. And we always work with the community rheumatologists if they want their patient to be involved in a particular trial. So we collaborate together on this.
And then aside from potentially getting involved in clinical trial, if you're eligible, is there anything that lupus patients can do to push a little bit more or advocate more for new drugs or drugs that are in the pipeline now and support that process?
I would say absolutely yes, because you can see what's happening now, unfortunately, with two major biologics that we have on the market, and history, it's repeating itself. I still hope that the resubmission for anifrolumab will be positive, and we do have now the portfolio as well for belimumab lupus nephritis, and we want these medication to get coverage. Otherwise, it has about equity and access to medication, and only certain group of people with good insurance plan will be able to access these medication. So I think I want to share with you, send the message here that Lupus Ontario and every lupus organization should team together and submit a file. And I know you did, but you gotta be more vocal. Target the people who are approving, who you're voting, who can approve these drugs. Because if you don't do this, we're not gonna get these medication for lupus patient. And I want to add here, if you allow me, rheumatoid arthritis, psoriatic arthritis, ankylosing, and all other rheumatic diseases, they got the biologic approved. I don't understand why it comes for lupus, we cannot get these medication approved. They need to better understand that prednisone is not the solution. Prednisone is associated with damage, and we can allow patients to have joint replacement, atherosclerosis at a young age. We need to change this, and we need your help to change it, the patient.
Kind of in that same vein with some of the new biologics that have come online, they're expensive. And there's a question as to whether or not they might be required indefinitely to be used or more just for a few months to resolve a very specific issue or serious flare.
I always say there is nothing indefinitely, okay? And it's a very big question here, because some patients, we learn that they can, their disease is monophasic, which means they can have activity for 10 years and then they go into remission. But unfortunately, this is not a majority of lupus patients, up to 7-8%. But the rest of the patients are active, what we call relapsing and remitting down the road. And in this particular group, we might have to be on certain medication until certain age where we call burnout disease. It slows down. So this is why really there is no single answer. In some people, you can do it. In other, you can't. And we've learned now with rheumatoid arthritis, because they've got the biologic on the market for a long period, they have been able in some of these patients to taper and probably lower the dose or change the way, the frequency of administration of the biologic. So for lupus, this is a very early question that I don't have a final answer on it.
We have another question that asks, I believe, whether or not there's a link perhaps between lupus and other illnesses such as Hashimoto's, hypothyroidity, plantar fasciitis even, and tendinitis. Is there a link between any of those conditions and lupus?
There is, because a lot of these diseases are related to the immune pathology. And often in lupus patients, we see that they have immune thyroid problem and they have specific antibodies against the thyroid. That leads in some patients to what we call low thyroid function, hypothyroidism. Not only this is why there is a risk for premature ovarian failure, because there are antibodies again to different glands in our bodies and organs, including thyroid and ovaries and others as well. So the answer is yes.
And one final question. We have a question about a drug. I think it might be similar to anifrolumab, or perhaps just a different name for it, Safnello.
Safnello is actually anifrolumab.
Okay, so we would have gone through the same kind of trial process, essentially, or was anifrolumab went through that process that you outlined in your presentation?
Exactly, it's just the difference between generic and trained names. So Safnello, it's anifrolumab, bottom line, like Benlysta and belimumab, yeah.
Okay. And in terms of the clinical trials, most of the data that was presented was for female participants, which obviously makes sense with the prevalence of lupus among women. Were there any noticeable changes or differences, I suppose, in the outcomes for men that maybe would have been different than presented as female?
Thank you for raising this very important question, because always, as we know, as you mentioned as well, it's more prevalent among patient females. But we know male lupus always, it's a major red flag, because male lupus, they do have very bad disease in general, where we see a lot of internal organ involvement and a lot of damage down the road. In drug trials, we did see as well male involvement in these trials, but has to do again with the prevalence of the disease. And we definitely see more females in these drug trials. But as I mentioned earlier, we have to keep in mind that male lupus do have very active lupus, and we need to be on top of the disease as well.
Perfect. Thank you very much for your time. We are going to have to end it there. We have a few more questions that I'll hopefully follow up with the individuals after today to get responses for. But thank you for your time. This was an incredible presentation. Thank you for joining us. And I'll just ask everybody now to please go to the next session on the agenda in that sessions tab, which is presented by the president of the Sjogren's Society. We'll see you all there in just a moment.